My name is Tianxing. I'm from Michigan State University, and it's my great pleasure to introduce our first keynote speaker for this IoT Day, MobiSys 2025. So our first keynote speaker is Martin Lukac. Martin Lukac is co-founder and CTO of Nexleaf Analytics. Nexleaf Analytics is a social impact technology company with the mission to partner with the countries to ensure that they have the data they need to build lasting solutions that improve the health of people. And in his role as a CTO, Martin oversees the innovations pipeline and the continuous improvement of technologies, saving lives in low and middle income countries. Okay. And Nexleaf IoT technology moves data from more than 26,000 health facilities around the world, and the technology has been deployed in over 30 countries. And Martin received his PhD and master degrees from UCLA, and his bachelor degrees from Harvard College. Okay, so now time is yours, Martin.
Thank you. Welcome, everyone. Thank you for coming to the early first talk. I know it's always hard on the first day of the conference. So I will say kind of the same thing, a little bit about myself. So I did my PhD in computer science from UCLA in 2010. I was working in sensor networks, or back then it was called sensor networks, in what was called the Center for Embedded Network Sensing. It's no longer around. Eventually that sort of sensor network tag, at least in industry, disappeared, and everyone calls it IoT now, as you probably all know. I primarily worked on wireless networks for collecting seismic data, and I also worked on some acoustic wireless networks, studying birds and marmots. My work really was focused on the overlap of communication, data quality, and really figuring out how technology can help researchers do their work and do their science better. I actually ended up doing some seismology, which was a lot of fun, analyzing the data from these systems that we deployed, and also ended up analyzing the data that was studying the birds. This really gave me a feel for the challenges with new technology and what it takes new users or new researchers, new scientists that are new to the technology to actually implement and make use of that technology and the data. And I'll come back to that theme a few times through my talk. So myself and my co-founder Nithya Ramanathan were both at that center, and after graduating we started Nexleaf Analytics. I wanted to also start by providing context on where I am now and where Nexleaf is now. Hopefully provide some validity to my experience and share what we've accomplished and what we're proud of. We're monitoring over 31,000 vaccine refrigerators in over 26,000 health facilities. Did this die? Oh no, there it is. In about 30 countries. We are a nonprofit tech company, and so we're focused on impact. We measure our success in terms of, as you can see here, the number of vaccines that we protect and the number of children that receive that protection from monitoring that we do. So this keeps cutting out, I think, but let me turn it around. As I mentioned, we're a nonprofit. So our model has been that we both sell devices. So we manufacture and sell devices and services. So we manufacture and sell devices and services around those devices, and we get grants and foundation funding that helps us work with the governments, the ministries of health, to ensure that the technology and systems get used and actually have an impact. So generally, we're working in the public health space, but we're not directly focused on patients and patient care. Our focus is more operational, focused on the medical equipment itself and the infrastructure to support it. So a little more context. For the past 8 or 9 years, Nexleaf has been around 30 or 40 people, so we're small. And a little bit later, I'll talk about how we're able to achieve the impact we have with such a small organization. We have maybe about 10 to 12 technical folks, which include engineers, data folks, product folks, and the rest are program, tech support, manufacturing, and operations. So this is another example of how we talk about our impact. What you'll notice is that we don't really talk about the technology a lot. We mostly talk about what it achieves, though it really is the technology that enables us to do what we can, or what enabled us to accomplish what we have. It's the IoT systems and the data that is collected by those systems that enables it all. So what I hope you all get out of listening to me ramble for 40 or 50 minutes or so is an understanding of what health tech interventions in low and middle income countries can look like. That technology itself is almost never the full answer. Building relationships and building ownerships through co-creation of these tools and technologies is super important. That helps with scale and success. Adaptability is the key. Many technologies that are developed for the US and Europe context may just not work in Africa and South Asia. And I think most importantly is that there's always a human element to scaling these IoT systems. Along with whatever you're monitoring, there's a need for maintenance and management, and that all requires people. So a little more context. So I've been using this term LMIC, low and middle income countries. This refers to the 60 to 80 poorest countries by income. There's lots of, you could think about what we do as essentially international aid work or public benefit work. There's lots of areas that like there's health, which we focus on, there's education, agriculture, environment, sanitation, water, and so on. Many of these international aid or public benefit efforts all include technology, and many have monitoring and evaluation components. It's something to determine, okay, we're spending a bunch of money to help some agricultural program or some health program. Did it work? Did it work or not? How well did it work? A lot of this type of information often becomes publishable, which is cool. For our health focus, we mostly work with organizations like UNICEF, Gavi, the Gates Foundation, Global Fund, World Bank. They all maybe do more than health, but within the health space, they all have slightly different models, but these organizations are fundamentally investing, funding, buying, procuring stuff, and funding implementations. And so they work with organizations like us and other nonprofits and the ministries themselves to try to improve whatever the topic or the focus area is. So as I mentioned, we're a nonprofit, and a lot of these nonprofits and social enterprises, they're working towards sustained impact. So they're building these programs, working with countries, and trying to bring improvements and bring interventions that implement some change. They're all generally focused on a class of problems or specific problems. For Nexleaf, we've had a bit of a journey, but all of them had IoT systems along with them. We started off in this clean cooking or cook stove space. We're not in that space anymore, but I will talk about it briefly. Our biggest success has been in monitoring the vaccine cold chain which I'll also describe a little later. And we're moving more broadly into monitoring medical equipment and health infrastructure. So how we started, during grad school, as we were working on sensor networks, we found a pattern. The pattern, and all of our colleagues at the time found the pattern, and I'm sure all of you, if you're familiar with IoT technology, are familiar with this pattern, which is there's a lot of new data generated and from these systems, and we need to work with the users, and in this case in grad school it was scientists, help them figure out how to manage, process, and get outcomes and answer questions with that data. As I think I mentioned earlier, I was working with seismologists, and my co-founder Nithya was working with people studying arsenic poisoning in groundwater. And so us and our colleagues at the time were applying this pattern of introducing tech, collecting data, and using that to improve the science. It's kind of a rinse and repeat. So we wanted to know, like when we were finishing our degrees, we were asking, oh, can we do this same process in the health space and environmental spaces? Fortunately, my co-founder had a colleague within the health problem space, and as we started looking and talking more, we saw a gap, that there was a lot of these aid efforts, the international work that I was describing that's working to help the low and middle income countries. We saw there was a big gap, and there was a big gap in terms of the data, and no one was implementing this type of pattern we were describing. Yes, they were maybe doing some, what they would call monitoring and evaluation, but that always ended up like after the intervention. So, they would implement something, and then they would go have surveys, collect a little data, maybe write a paper, and then things would sort of stop there. And so I want to give a couple examples of what that looked like, and what are some failures of those, or what we see as failures of those processes. And so keep in mind this was around 2009, 2010, so a little while ago. And this was, just to contextually place that, this was when smartphones were just starting to take hold. So there's this space called clean cooking or clean cook stoves. So, and my numbers here are maybe a little outdated. I don't know if this has gone up or down, but at that time, each year about 3.8 million people die from indoor air pollution. That's from cooking, as you could see in the picture, on basically open fires, finding whatever they can to burn to cook. All the soot and smoke from those fires causes more deaths than HIV, AIDS, malaria, and TB combined. So this is a huge problem. It's been a huge problem. So what was happening around this time was there was dozens of organizations trying to build better methods of cooking. These contraptions, these cook stoves, which would burn the fuel more efficiently and create less pollution. And they were getting funding left and right and deploying these cook stoves and claiming, hey, yeah, we deployed these. We're having impact. This is working. It's working well. But what would actually happen is if you go and visit any of the sites that they were deploying, you'd find the cook stoves either broken or not used. And of course, if you talk to the people that got those stoves, they would be like, oh yeah, it's great, I love it. So there really was this lack of bringing data to these problems. And this is, 15 years ago, this is what we saw consistently. Another example is, and this one's like happening now and has been happening for the past 20 or 30 years, is if you go into any hospital in any of the low and middle income countries, or generally the 60 poorest countries, you will find a room that's full of broken equipment. This is what's canonically known as the equipment graveyard. And there's some estimates that about 40% of that equipment is broken. And so what's happening? Why is that the case? A lot of people have a lot of reasons, and there are a lot of reasons as we've looked into this. And it's not getting better. And so this is another problem that's sort of ripe for monitoring, for IoT, for collecting data, to really both understand the problem, but then surface data to help tackle the issues. And I'll talk a little bit later about how we're doing that. Also, the second point there is that power is also a problem. So a lot of the devices and equipment that are built or distributed and bought and to these countries isn't built for this context where the power may go out at any time. So Nithya and I, our co-founder, we saw, at the time we were starting, we saw a lot of potential for IoT, for using sensors to collect this data and help these types of interventions. But what we were looking at wasn't, at the time, the typical IoT stuff, which was industrial monitoring, smart cities, all of that. So our first few years, we were monitoring the cook stoves. We actually had another project where we were monitoring birds. We were talking to water providers. And people were telling us that we were all over the place in terms of scope. But for us, we saw the same pattern. We saw that same problem, which is collect the data, understand the context, be really clear about what the problems are, what the data is indicating the problem is, and then work to provide analysis to help solve those problems. And as I've been talking about, we saw a lot of, we felt like we were the only ones actually in the public health space that were trying to measure and understand these interventions that were happening. Fortunately, it's gotten a lot better since we started. So, as I mentioned, with that cook stove problem, we started off by simply monitoring the temperature of those cook stoves. Like, is someone using it or not? And tracking whether it's working or not. The way we started doing this with the cook stove work was we put a phone in a box. We prototyped really quickly, and this was like the second or third gen Android phones. We were able to connect to temperature, and we were able to monitor those cook stoves. And quickly found that by generating this, what we would call objective data, yes, this is use in this stove is in use or not in use. We were able to then talk to the users and be like, hey, we see you're not using this. Tell us what's wrong. Tell us why it's not working. And that sort of simple loop of bringing the data to the users and talking about it with them and talking about the analysis helped sort of build this culture with the folks we were implementing this work with of actually bringing validity through data to their work. And so, we set up dashboards, we built displays, we analyzed the data, and in that cook stove space, we like to think that we were instrumental in bringing this data culture to that space. Pretty quickly, as we started doing this work on cook stoves, we found the vaccine cold chain use case. So there's about $2 billion spent on vaccines for the 80 poorest countries each year. During COVID, obviously this number was a lot bigger. I think it was up like in the 7-8 billion. And as you all probably know, vaccines, they need refrigeration. They need what's called a cold chain. Only a small fraction of that $2 billion is actually spent on that infrastructure. If the vaccines get too hot or too cold, if they freeze, some of them, if they freeze, will lose their potency, so they're no longer ineffective. So you can imagine there's these organizations spending all this money on distributing vaccines, and they don't know if those refrigerators are working. And these are refrigerators in remote locations in Africa and South Asia. So the state of the art at the time were basically paper charts. So nurses are expected to twice a day these nurses who are already overburdened are expected to go twice a day, open the fridge, look at the temperature, write it down into a paper chart. These paper charts, they may get collected, they may go to like a district center, someone may put it into Excel, but in the end, no one was looking at this data. And so we, very quickly asked the question, hey, why isn't anyone monitoring these fridges? We did find that there were people monitoring like the national cold room, which has maybe a couple $1 million worth of vaccines in it, but no one was monitoring the remote facilities. And those are, the vaccines may sit in there for up to a month, so it's really critical. So over time, through our work, we were able to demonstrate that there is an ROI, there's a return on investments for even monitoring the remote facilities, even for these facilities that have just a few $1,000s worth of vaccines in them. And so here we also started with a phone in a box. That helped us very quickly collect data and demonstrate what I described, that there is an ROI. And we also found a lot of interesting things, like those paper charts, they actually never matched the actual data. And so what we found was happening, a lot of the nurses were backfilling the paper. And it's not because they didn't care, it's because they didn't have the capacity, they didn't have the training, the system just wasn't set up to support them in doing this job of monitoring the fridges successfully. So with the data we were collecting, we were able to quickly start focusing on visibility and action. We also very quickly learned one of those lessons I mentioned, which that the technology wasn't enough. Same as with the cook stoves, here it wasn't enough just to put the technology, in this case the monitoring, on the fridges and set up some alarms and hoped it work. So we spent a lot of time working with the communities, setting up the right type of alerts, building dashboards for like the district managers and regional managers so they had the data they needed, and we worked with them to develop the processes they needed to actually monitor these fridges. And we also worked with the technicians to help them identify and be able to better use the data to solve problems when they happened. So early on, like I mentioned, we did an RCT. We did a study to try to determine, hey, does this system actually have an impact? Does setting up alarms and monitoring these fridges and providing that data have an impact? We did find out that there was a significant improvement. You could see green here means temperatures in range, and red is too hot, and blue is too cold. If you look at the right side, you could see just setting up this data and ensuring people had access helped clean up a lot of those problems. The one thing we weren't so happy about is just doing this as an RCT. That meant, randomized control trial. I didn't define that. That means you basically have a control group that gets nothing, and then you have one or two other groups that get different versions of the intervention. And we weren't super happy about that because we meant we were holding back the ability for the control group to actually make improvements and use the data to keep these vaccines potent. So over time, we've sort of changed our model and changed our thinking to really work to figure out how to have the intervention itself be the actual monitoring and the intervention itself to actually speak for itself. So around 2014, we started getting a lot more interest, and so we moved from a phone in the box to manufacturing our own devices. The one on the left is the first one we built. It was just a super basic, low-cost focused device to monitor temperature. It had 5 wired temperature sensors, a basic 2G modem in it, and we manufactured this in India. With that device, around 2015, we were able to get our first large-scale deployment. There was about 14 to 15,000 devices, which we believe was the first largest public health IoT network in low and middle income countries. And it was deployed across 8 states in India. Since then, we've developed something a little bit more modern. We have that middle one, a base station with Bluetooth sensors, and this has really been designed with this low and middle income country context in mind. We also made it sure that so that the sensors themselves can be used to monitor the transport of vaccines, because the vaccines not only stay in these fridges, in these public health facilities, but they're distributed through these countries. So I'm about halfway through the talk, so I thought I would pause and collect the learnings so far. I've categorized these into obvious and less obvious. Maybe, hopefully for you as researchers that are working with technology and people, this is hopefully very intuitive. The first one is that the technology is not the answer. Building the tech and handing it over and hoping that it works is not good enough. We often find it's not built for the context, it's not built for the everyday, and you know, everything from the interfaces on the system to the workflows you hope people sort of engage in, and the overall understanding of how the system works, how it's supposed to be applied. And the best example of that is the one I've already given around the cook stoves. Like, you know, hundreds of thousands, maybe, at least tens of thousands, if not hundreds of thousands of cook stoves in the early days were distributed, and they just never got used. It was just a big waste. And so that piece of technology was not successful, and no one was figuring it out. The second kind of still obvious learning is that user-centered design and actually building relationships to help solve the problems is important, particularly in low and middle income countries. The folks we work with are really resource constrained, and they really want to own these systems and own the intervention and own the technology. And when you engage in that process, you're actually able to build technology better from our perspective, and you're able to build it in a way where you build the technology component and you build the people component as well. We really had to keep in mind from early on that these weren't consumer products we were building. And we couldn't just sort of hope to have, you know, thousands of users immediately trying something and giving us feedback and helping us improve our product. We really had to engage and build the relationships with the ministries of health, with the nurses, with the biomedical engineers to really understand this. Where we are now is the way we work is we actually build MOUs, or essentially agreements with the ministries of health that we're working to solve these problems together. And that helps them put in resources and helps us then also get more resources to help solve the problem. So maybe the less obvious category, the first one here, is that the commercial off-the-shelf technology may just not work, especially in low and middle income countries. Enough so that we chose to build and manufacture our own devices, the things I show on the previous page. Examples of this, you know, over the past month or two, I've been looking online for new Bluetooth IoT gateways to see what people are building and what's out there. I've found very few of them have backup batteries. In low and middle income countries, in these health facilities, you need a backup battery. If the power is going to go out, I actually have some data around power I'll show you a little later. The power is going to go out, the power quality is going to be poor, and so the system can't work if the power's out, if it doesn't have a backup battery. Another example I have is a lot of the new gateways that are out there, especially the lower cost ones, they only have NB-IoT and CAT-M, or the LTE-M. They don't have 2G, they don't have 3G. Most of the countries we work in, they have 4G, but they haven't turned on, they haven't configured, they haven't set up management for CAT-M and NB-IoT. So, we need devices that have the full set of capabilities. And many of these countries are nowhere near shutting off 2G because that's like the only thing that works in the most remote facilities. Another less obvious learning we've had is that there is a large human dependency. A lot of the interventions we see, a lot of the technology deployment we see, the human element is missing. An example is And it's basically like an understanding that people are needed to manage and maintain the IoT systems and the technology. In one country we worked in, the ministry wanted to take over management of the SIM cards. And we're like, great, this is wonderful. You know, we want the ministries to own and run these systems because that's how we can ensure that there's sustainability. This one country, they figured out how they wanted to do this. We handed over the ownership to that, and within the first 2 months, about 70% of the devices went offline. They hadn't set up their processes and their practices around managing those SIM cards successfully. Since then, you know, it's all been solved. Like the data quality is much better, and they were able to address that problem. But that example shows like there really is this human element. You can't just expect things to work. Another example I've seen, this is not with our work, but with other work, we know a group that's deploying a smartphone and ultrasound solution to help nurses and healthcare workers do prenatal scans of pregnant mothers. And they're stepping up to their sort of next phase of trials where they're deploying 200, 300 of these. And we asked them, hey, who's managing those assets? Who's managing those devices you're deploying? What information are you tracking about how they're used and, you know, whether they break or not? Who's setting up the supply chain for the ultrasound gel? Like all of that. And they hadn't thought about that yet. They missed this human element of managing this technology and with its distribution. I think I'll just talk about one more of these. This other less obvious learning is that for us, for a lot of what we do, the return on investment is not direct. You know, we haven't built and implemented a technology that's like directly monitoring patients. So we can't say like, oh, we saved this many patients, or we saved, you know, we improved this many, you know, we had this large of a health intervention that had this big impact. For us, it's been a bit of a challenge to communicate about like how we're focused on the operational aspects. And yes, there's cost savings, but overall, like there's that secondary effect of more children getting more potent vaccines. My last point here was about subscription models are not sustainable. We see a lot of people going into the health tech space hoping to have some sort of subscription model because they want to continue improving the devices, improving the services. But in a lot of contexts, these health systems aren't set up to pay monthly subscription fees or even yearly subscription fees. So there's a lot of challenges around that. And that's something I'm really interested in talking about offline if anyone wants to talk about these models for sustainability and around health, around these health interventions. So what did I learn? And so I'm setting up next to talk about like where we think this is all going. But to get there, I want to sort of describe like, you know, what did I learn? How were we able to do this, to dive into these resource-constrained spaces and figure out how to get these technologies to work? So during my PhD, like I learned to work with data. Back, you know, in the 2000s, that wasn't a huge requirement when you were going through undergrad and grad school. I think it's gotten a lot better now. This ability to frame and break down and approach problems, I think everyone as a PhD student really learns that. It was really important because we needed to convince people to fund us. And being able to speak to the challenges and how we saw technology being poorly applied in these low-income country contexts was key. Then a lot of experience debugging, tinkering, and getting things working. It's something I think most PhD students learn. Then understanding and adapting and matching tech to requirements and user needs. So as an organization, right, I mentioned we're 30, 40 people, but we have this big impact. We have this scale, right? Our IoT system isn't on the scale of some of these massive ones that are out there, but you know, we're doing countrywide coverage of all the public health facilities in 5 countries. And for us, that's huge. So we were able to do this because, you know, we started out as a bunch of engineers and a bunch of program and public health people. So it was really this, this partnership across different sectors that helped us do it and helped us build the compelling cases. We were also very quickly able to build partnerships with other nonprofits and these funders. As an organization over the past few years, we finally added a product function, so we now have product managers, and that's been a huge acceleration, and we're like, why didn't we do this earlier? Just having people that can really work with the users and really get to the core of the problems and figure out how the technology can most easily fit into their day-to-day lives. We also have a program function, which is, you know, generally public health folks that know how to speak about the impact and frame the work to funders and actually the ministries in really successful ways. And finally, country functions. So we, in you know, those 5 countries I mentioned that we have the largest scale, we have at least two or three staff members in each of those countries. And that's been super important, building the relationships to deploy the technology and ensure its success. So where do I think at least IoT technology in the low and middle income country context is going? The big sort of problem we see is that data production is growing. So there's more and more data out there, more devices generating data, but people don't have access to it or don't have easy access to it. A lot of pushback we get is, hey, not everyone has a smartphone, or, oh, they already have to log into 2 other systems, or they don't have a laptop with a data connection, or the biggest one we hear is they don't want to use their personal data plan to access these systems and access this data. And so we see the key, the future of this direction as integration and standardization. And I mean integration in multiple ways. The first is the integration of the data itself that the IoT systems are collecting into other systems. We find, yes, it's cool, we have our own dashboard, we have our own metrics, we have our own reports that people can use, but they're already logging into other systems. They are already looking at data either around you know, logistics, like what vaccines are being distributed, or they're looking at health metrics, like, you know, how many people were treated for malaria, or how many people were treated for pneumonia, how many cases of different diseases they had. They're already looking at those systems. And so integrating the IoT data into existing systems is key. It's something that we see can really help drive the impact for more reasons than one, and I'll talk about that a little later. The other integration is integration of IoT capabilities into more equipment. I think we take that for granted here in the US, that everything now has Wi-Fi or everything now has Bluetooth, and you're seeing more and more of medical devices to have that. But having that capability in lower cost equipment like incubators, oxygen concentrators, CPAP machines, we think can be game changing. Even if it's not communicating the data, even if it's at least logging the data, you know, logging error codes, doing basic self-diagnostics, like, we think that can have a significant impact on the equipment graveyard problem, which I'll get to in a minute. So the applications we see for IoT in these contexts is, as I've been mentioning, the equipment graveyard problem, so integrating more technology to generate more data, and then power quality. I mentioned before, like a lot of these countries and a lot of the contexts, power goes out. Power quality is really poor. Kind of related to that, and this, if anyone's interested, I would talk about this one offline, but cooling, right? The world is warming up. There's going to be bigger and bigger demands on power as people implement more cooling, both for their personal and business spaces and for products and goods. And so then all of those need manufacturing and, or sorry, need maintenance and some accountability. So I'll skip this one. So yes, so why is power important? So facilities need power to be able to provide, these health facilities need power to be able to provide the health services. So there's often, you know, power outages or brownouts on these overtaxed power systems. You know, you may say, oh, solar can solve the problem. We've seen dozens of solar installations where, yeah, they get installed, it works fine the first year or two, but then there's no maintenance. There's no management of that system to ensure that the solar keeps working and keeps working well. So as an example of how bad the power problem can be, with the device that we're monitoring the vaccine fridges, we also record power availability, so whether there's power in the facility or not. So what you see here in this plot is each bar is a day, and it shows the number of facilities that have, you know, either 20 to 24 hours of power a day, 8 to 19 hours of power a day, or 0 to 7 hours of power a day. Right there, like towards the end of January, this country had a typhoon, had a hurricane. And you could see it knocked out the power a lot. So there was a lot of facilities that just like totally changed the characteristics of how many hours of power a day they had. That's expected with any typhoon. But what's more interesting is over the subsequent months is the pattern didn't return to where it was before. So a lot of these facilities and a lot of the power system was damaged and wasn't able to recover to the levels of service that it had beforehand. Since then, it's gotten a lot better as we've monitored the data for, you know, this was in 2022 since then, but it took a long time to recover. And that means less facilities with less power to provide the services that are needed. This is an example of power quality across 10 months. Each of those little symbols means either like an impulse, a sag, some sort of surge in the power coming directly into the facility. We collected this with just a sophisticated data logger, no IoT capabilities, just a logger. And you'll see a lot of gaps. And that gap those gaps were happening because this data logger only had like 8,000 rows, right? It could only have 8,000 entries, and it filled up really fast. And we weren't able to visit it to collect the data enough. So as a contrast, I had one of these same devices in my home in Los Angeles, and over this time period, there were only 2 blips. There were only 2 little symbols. So you could see the power quality is bad. And so more monitoring and more data like this to help improve and tackle this sort of problem is something that we see in the future. So I've mentioned this equipment graveyard problem a few times. That same pattern we saw before where technology gets deployed, this equipment gets deployed, and for some reason it stops being used or breaks, builds up these equipment graveyards. And as I said, you could walk into most hospitals in Africa and you will find a couple rooms filled with broken equipment. And so we wanted to see if we could take this same pattern, this same approach that we had applied with the cook stoves and with the vaccines and apply it here. So what's the data we could collect about the equipment to help understand like why it's being not used or what's happening, use the data to surface what problems are happening. And so in about 2019, 2020, we did some pilot deployments where we used actual off-the-shelf technology. It wasn't the best fit. It was too expensive. It used too much data. Like we were running this all over cellular networks, and it used way too much data. And none of it had backup batteries, so anytime the power went out, we lost the data stream. And so we deployed this on a couple hundred equipment in India and Kenya, a bunch of different equipment types. So we were monitoring the power usage of the equipment so we could tell if it's being used or not. In some cases, we had little accelerometers on devices to understand whether those were running or not. And as we put all this data together, we started working with the biomeds, the nurses, and the administrators at the hospital, and we found a lot of interesting things. We were basically able to flesh out a number of use cases, but we found things like, in one facility, they were shutting off all the baby warmers at night. You know, they were taking proper precautions and bundling up the babies, but they had basically implemented a policy on their own at that facility that they don't trust the electrical system. And the technician that can, you know, do repairs or manage problems with the electrical system wasn't there at night. So they just decided not to use the baby warmers at night. And, you know, that type of information, that the utilization we collected, knowing whether these equipment was being in use or not, helped surface that problem. Other examples are, you know, in one facility there were 5 incubators. They never used 2 of them, and so we went and talked to them, like, hey, why aren't these being used? Turns out one of them they didn't trust, the other they couldn't get spare parts. That information never surfaced and never went up to the hospital admin and the district administrators. And we started surfacing that information, and all of the folks we talked to were like, this is great. I can use this data. The folks we worked with just had this intuition, like, I can use this data. It's more than anecdotal. It's actual concrete data, you know, in charts, in CSVs, in Excel, and I could use this to advocate for the resources I need. And so this is the direction we're going, where we see IoT data essentially collecting information about what do the ministries have, like what equipment do they have, whether it's being used or not, whether it's working as it's supposed to work, and that's the IoT component. Getting that data integrated with the other types of data I was talking about earlier, that integration with you know, health outcomes or service delivery, is crucial, because these hospital admins, you know, the national managers, they can put this data together and really make a case for, here's what we need. We're seeing, you know, dozens of cases of this disease, but we don't have enough equipment to handle it and to even diagnose it or treat it. So let me see, I'm gonna wrap up here shortly. Oh, yeah, one of the questions I was prompted with is, how can you integrate AI? And I think we're gonna talk more about that in the panel in the end. But I just wanted to briefly mention, like, the AI, which I sort of refer to as phase 1 of AI from 5 to 7 years ago, for our context and what we were doing, it wasn't really helpful, since 95% of the problems didn't need that solution. It just needed a basic heuristic, a basic alert, a basic report. And so there's been no big drive in our space to, like, let's predict a fridge failing, let's predict a piece of medical equipment failing. The context is that they already have a number of fridges that aren't working, and they're struggling to get the resources to fix those. So knowing another fridge is going to fail wasn't helping. And so our users, honestly, you know, they were interested in that idea, but in terms of being able to apply it, it wasn't helpful. However, that changes now with generative AI. This can actually support operations. It could support on-the-job training. A lot of the ministries we work with have staff turnover problems, and it can help with the access to data. And so we do see a strong future for AI with IoT in these low and middle income country contexts. So just quickly, the final learnings we have and the things that we see are needed from IoT systems being deployed in the future is models for managing the systems or managing the technology. It's not explored enough in the spaces we work in. Funders are getting better about this, but it still needs a culture change. We've learned very quickly, especially through the medical equipment work we've done in the past few years, that if you give the data to the users and they understand it, it could really empower them to advocate for the resources and the changes they need. And then just power is an issue. So one last slide. I just had a few quick opinions. I won't dwell on this too long, but the type of work we've been doing, we don't see it as like full-fledged research. It's taking existing ideas, taking existing technology and working to adapt it and make it work in the context that we work in. And as I mentioned, the aim, really what we're trying to see and trying to convince the sector of is build these interventions, build these programs to provide the measurement as you go along and as you're working towards the impact. And overall, in the broad IoT space, like we feel, especially for the context we work in, we think there needs to be more innovators. So folks like us that are trying to take all the technology and all the research that you all are developing and figure out how to make that work in the context that we work in. So yeah, that's it. And I'll be around all day, and I'm very happy to talk about how to learn more about these various types of challenges, how to find this work. I have a number of resources for all of that. So thank you.
Thank you for the quick talk. Now we have time for questions. You can go there. Yeah. Make sure you turn on the microphone.
Hello? Yeah. Just out of curiosity, why were those stoves in India not used, or the rest of the LMIC countries?
Stoves, there's dozens of reasons. Sometimes the stoves would break too quickly. Other times the method they had to cook was just like, it was too tedious. They either had to chop the wood smaller or they had to, figure out like the patterns of use. They didn't like it. They didn't like the way the flame came up. They didn't feel it, made the food the same way. Like there was a whole bunch of challenges. And the point was that the people developing that technology weren't using data to try to improve it and try to make it better. They were just like, yeah, we built this, it's great, it works in my lab, here you go. Since 2010, 2013, it's gotten a lot better, but we're not in the space anymore. Like we did what we came and we got them to use data and people to iterate on their designs and their interventions, so. Yeah.
Thank you.
Well, thanks for the great talk. So I have seen that your company has been developing like different technical solutions, IoT solutions for the developing countries, right? So my question is, regarding these IoT solutions, when you're developing in the developing countries like India or those African countries, what do you think is the most important constraint for developing products in these countries compared to like developing similar countries in the similar products in the developed countries, like in the US, for example? Is that the cost, for example, or the reliability, or the independence from the infrastructure, or so which aspect do you think is the most important?
I feel the cost and reliability are big, but I feel like it's the human aspects. So again, it's like you can build the technology, you could build the most robust, cheapest thing, and you could get it deployed, but if you're not, particularly when you're working with the public systems, and so I'm not talking about like an industry, like a for-profit company trying to, improve their operations by deploying an IoT system. I'm talking about the public systems, so the government ministry-run systems. With those, you need to bring in that human element. So you need to co-create, and you need to build the policies, the practices, and build a culture of using these and figure out how to integrate it into the everyday practices. That is, to me, the biggest hurdle for the adoption of these. And you obviously have to make the case that, you'll save money or save lives and all of that. So, but the robustness and the cost help a lot.
So does that mean for like providing or developing IoT solutions in these developing countries, those like more regulational or non-technical aspects going to be more important than the technical aspects of like developing technologies by themselves?
Sorry, what do you mean by technical aspects?
Like tech aspects means I just want my products to be cheaper or last longer, right? Non-technical means, like you said, like handling those public sectors.
I think they're both important. It's the resource constrained aspect, and like I said, a lot of these ministries have some staff turnover problems, so they'll hire someone, they'll stick around for 6 months to a year, and then they'll leave. They'll find a better paying job or something, and so that knowledge and that experience using the system, using the data is lost. Yeah, I lean more towards the human aspects again here over the technical ones, but the technical ones are still important.
Okay. Thank you so much.
Hello, I have a quick question. So I think in the beginning of your presentation, you talk about the challenges, and one of the challenges you mentioned is that the government or the administrative team that your company work with, they tend to take the ownership of the product that you guys develop. So what's the incentive for them to take the ownership of the product if the maintenance cost is not trivial and it's technically hard for them to maintain the product?
Their motivation is what happens if we go away. Their motivation is they want to build their own capacity, right? They want to be owners of the solutions. It's much easier, it's much easier for them to sustain and find funding for work that they're driving as opposed to building in something into their budget to pay some third-party company to do something. It's somewhat some of their policies, and it's somewhat some of how they approach it. And we actually like this because it is about capacity building. It is about supporting these countries and building their capabilities to own and manage these types of systems. It makes the incentive for other companies to come and provide more solutions a little less, because it's like, well, we want to continue doing business, but then the ministry wants to take over the thing. So there's a little bit of a counter incentive there. But ultimately, it comes down to, one, what happens if the company or service goes away, and two, it's a lot easier given their policies and processes for them to fund their own people as opposed to make a line item to pay for a third-party company to do something. So,
Thank you.
Okay, maybe I can ask one last question. So during your keynotes, you talk about a lot of lessons you learned, and as we discussed in the morning, our community also built dedicated systems to solve some real-world problems. One of the challenge we were facing is that when we build such dedicated hardware systems and start collecting data, we are not able to collect big data due to various reasons. We can only collect small data set. So I'm not sure if you have faced such problem before, but in your opinion, do you think the future AI can help address such small data set problems? And just share some of your suggestions.
I missed it. What prevents you from collecting the data? Is just the lack of people, lack of enough?
Yeah, as academic research, we cannot collect data from a lot of users due to various reasons. Yeah.
Fortunately for us, since we're operational and not sort of focused on people, it's a lot easier. Yeah. We have had, in a couple of our studies, even though we didn't, and the people we were working with didn't feel it was necessary, we still went for like IRB approval, if you're familiar with that sort of thing.
Yeah.
the best thing I can say is you just have to build up partnerships. You have to find people that can get you access to more folks. I haven't thought about how AI can help there to get more data. Yeah.
Okay, thanks. All right, so the first keynote will stop here, and we're gonna have a short break, and the next keynote